Hello, my name is Dr. Leon Creaney, a consultant in sport and exercise medicine based in Manchester, UK. I wanted to speak to you today about groin pain in sport with a particular emphasis on the football codes. Just before we begin in earnest, a little bit about myself. I'm based predominantly around Manchester at various hospital locations where I see private patients. And also do virtual consultations via Zoom and Microsoft Teams. This is an important topic in sport and exercise medicine. It's very common in all of the football codes, can often be quite difficult to diagnose and treat, tends to be recurrent if rehabilitated poorly, and there's a lot of controversy and schools of thought around the interpretation of physical signs and imaging, and it does very much depend on which guru you happen to see, what your final outcome may be. I'm going to predominantly talk about the medical aspect of groin pain in this talk. I'm not going to talk a lot about surgery and surgical technique, though I will mention surgical technique for completeness. Before we begin about the diagnoses themselves, it's worth having a revision of anatomy. Some important aspects of anatomy in the groin to look at here are the symphysis pubis, this area known as the pubic bone or pubic tubercle, this important ligament here called the inguinal ligament. Looking at this bone from the side, the joint formed in the middle is known as the symphysis pubis, which is a synovial joint. We have the superior pubic ramus and also the inferior pubic ramus. Again, looking at these from slightly different views, the superior pubic ramus, the pubic body and pubic tubercle, and the inferior pubic ramus. The inguinal canal and inguinal ligament is a very complex anatomy. There are three layers essentially formed by the transversus fascia, internal and external obliques. I wanted to draw your attention to the conjoint tendon here, formed by the deepest layer transversus. And coming on to some less textbook anatomy, recently recognised and given different names by different people, where the rectus abdominis muscle inserts into the pubic bone, and there is a fascial continuation, which some people believe is continuous with the adductors. This has been named in some papers as the pubic aponeurosis. The pubic bone can be seen here on an MRI scan. This is a torn pubic aponeurosis where it's avulsed away from the inferior surface of the pubic bone. Other surgeons go into deeper anatomy and have renamed this the pyramidalis anterior pubic ligament adductor longus complex, which is quite a mouthful, shortened to plaque. What others call the pubic aponeurosis is now named the plaque, and various tears can be sustained in this area. The groin is a very complex area of anatomy, not least because there are multiple different muscles acting across the joint, leading to a delicate balance of forces, which can cause twisting and turning forces. If we look here, we can see the rectus abdominis above, the adductor longus, gracilis, and even the adductor brevis providing force laterally, and other muscles not shown here, such as the iliopsoas muscle crossing near to the joint. There are really four major areas of focus that I wanted to talk on today. The so-called inguinal disruption and inguinal hernia, adductor-related pain, pain related to the pubic bone and the symphysis pubis, and pain related to the plaque complex or the pubic aponeurosis, and also the hip. And we will of course need to give mention to the various nerve entrapments around the groin and potential referred sources of pain. The differential diagnosis in groin pain is obviously very large. This is taken from the Doha paper, and even this is not exhaustive. There are many different ways to examine the groin. Prevention is very important. Various papers have been covered looking at what can be done to prevent adductor injuries. This is work done by Per Holmick's group and has been published in various journals. FIFA has of course introduced the 11 plus, a balanced warm-up routine to be done during training and pre-match. This is all available on the FIFA medical websites and has been demonstrated to prevent not only groin injuries but injuries to other parts of the body, particularly in football. So moving on to our first major area of focus, what was formerly known as a sportsman's hernia or Gilmore's groin. The preferred term by consensus now is inguinal disruption, as agreed with the Vienna statement and also the Doha statements. We don't prefer to use terms such as athletic pubalgia, which is predominantly a North American term, sportsman's groin or Gilman's groin or hernia, as these terms infer that a true hernia is present, when in reality this is really the case. Inguinal disruption, agreed diagnostic criteria you can see in the red box there. However, this is often a diagnosis of exclusion where no other obvious pathology accounting for the pain can be seen and addressed. These 5 criteria don't all need to be present, however most of them should be, at least 3 out of the 5. Things that will give you a clue also would be pain when coughing, sneezing and when performing the Valsalva manoeuvre, but it does largely remain a diagnosis of exclusion. There is controversy as to how common the condition is. Some studies report it as being very low incidence. Other studies report it as being very high. It does vary greatly depending on whether it's a hernia surgeon who performs the study or a sports physician, and what the predefined diagnostic criteria are. Ultrasound can be very important in the diagnosis in terms of inclusion and exclusion of this condition. A hernia is defined as movement of intra-abdominal contents through the inguinal canal or pushing against the inguinal canal, and this can be observed on ultrasound. We see 3 pictures here. We can see the inferior epigastric vessels in the picture to the left, and as the person performs a Valsalva manoeuvre, we see herniating tissue gradually increasing in size as we go along. The inferior epigastric artery and vein are shown there in red and blue. As we perform the Valsalva manoeuvre, we're looking at this pink area here. That small area that starts off brown. As we begin the manoeuvre, it's seen to enlarge and enlarge again. And this ballooning and bulging superior to the level of the epigastric vessels is ultrasound diagnostic for herniation. How reliable is the test? Well, it's very open to interpretation, as everything is on ultrasound. It's very much useful as a test to rule out hernia. If we don't see bulging of tissue in relation to the epigastric vessels, then we can confidently exclude a hernia. However, what is known is that many people do have asymptomatic hernias, so the test is not very useful for ruling it in. In this particular study here, we can see that 61% of asymptomatic players who had no pain around the groin, you could still observe bulging on ultrasound within the inguinal canal. As a result, ultrasound can be very useful, as I said, to rule out hernia as a cause of pain, but presence of a hernia on ultrasound doesn't necessarily rule it in as the cause of the athlete's pain. Is there surgical management of hernia? Well, obviously there is. Different surgeons describe different techniques. This is the Lloyd release, as well as doing a standard hernia repair to release tension around the groin. The inguinal ligament and lacuna ligament are released. Or there is the Manchester groin repair, a total extraperitoneal approach using, again, mesh fixation, but also with fibrant glue. Now, moving on to adductor-related pain. This is also very common in sports that involve a change of direction or kicking. And what you can see here is quite a severe case of bilateral adductor tears with an injury to the plaque as well. We can see here the injury on the inferior surface of the pubic bone. The plaque or pubic aponeurosis pulled away and extending into the left and the right adductor origins with a few millimeters of retraction. It's important to examine for adductor related pain, palpation around the adductor origins and inferior pubic ramus, and of course doing the squeeze test. There's various tests that you can do for adductor-related pain. Palpation of the adductors seems to be the most sensitive and also the most specific test, although you can see from these various tests which have been researched, no test is particularly specific for adductor-related pain, and there is plenty of crossover with pathologies in other areas. Again, in terms of sensitivity and specificity, MRI is quite useful as a discriminating tool. Again, it's very sensitive for adductor tears and tendinopathy and probably has the highest level of specificity also. If you're not familiar with the adductor squeeze test, this is the squeeze test being done at the 45 degrees hip flexion position. It can also be done at 90 degrees of hip flexion and straight-legged 180 degrees. Preferably, if you're rehabilitating somebody, you do this with manometry. You would blow up a sphygmo manometer to 20 millimeters of mercury and ask the patient to squeeze as hard as they can and see how much pressure they can produce in the three positions. You can do that in outer range and inner range, and improvements in those scores are a good factor in rehabilitation. If you're working with a team, you can actually take those scores pre-season so that you've got a benchmark to rehabilitate against if someone gets injured during the season. There are operations described for this also. The most frequently described would be a simple adductor release. If you're unable to get rid through rehabilitation of tension-related pain in the adductors, they can simply be released. Obviously, there is a trade-off there in terms of loss of power, and you do have to strengthen associated muscles in response. So that would certainly be considered a last resort type of surgery. We've talked about this earlier, the so-called pubic aponeurosis or plaque injury. Some authors would represent that inguinal disruption and sportsman's hernias are actually this condition which have been misdiagnosed. This is again a finding that you see very frequently on MRI. Pain around the inferior surface of the pubic bone with the associated MRI findings and a positive adductor squeeze test would be findings that pointed towards this diagnosis. There are in fact different patterns of injury that you can see on MRI, the so-called superior cleft and inferior cleft signs, and what we're talking about here is either an avulsion around the superior pubic ramus on its inferior side or the inferior pubic ramus on its inferior side. They would be the superior and inferior, secondary cleft signs respectively. You can do diagnostic injections to these areas and get transient improvements in pain, and also get a pain-free window in which to do rehabilitation. This is a fluoroscopic view of a contrast agent injected into the symphysis pubis, and you can see that rather than being contained within the joint itself, contrast is actually extravasating into the superior cleft and the inferior cleft or secondary cleft, indicating that this person has not only a pubic aponeurosis injury but also an adductor microtear on the right hand side. And this is a corresponding finding where you can see that the contrast is contained around the superior cleft, but it's leaking into the left adductor origin. And this is 3 scans here of an injury where it's crossing the midline, so an injury on both sides. And you can see the corresponding fluoroscopic images where it's gone into the superior cleft and inferior cleft upon injection. Again, you want to correlate your clinical findings with the radiological findings, and this does show you in one study how response to injection correlated with the clinical and MRI findings. 89% of patients experienced an improvement with a symphysis pubis injection, but only 47% of them got complete resolution, with 42% getting a partial improvement. So this can be very useful to give a patient an injection to give them complete or partial pain relief and give them that pain-free window for rehabilitation. So moving on to rehabilitation. This is very much the Dublin experience, the sports surgery clinic in Dublin there, Aina Falvey, Andrew Franklin Miller and Enda King. And this is really a stepwise rehabilitation program for people presenting with sporting groin pain with any underlying etiology, and they describe a 3-level stepwise approach to rehabilitation, which could be used for any of the previously mentioned diagnoses. Level 1 is very much focused on static exercises with intersegmental control. Moving on to level 2, which is straight line mechanics and running load, and finally on level 3, when you introduce a change of direction and multi-directional control. So these are some of the level 1 exercises that you might use, where you're doing single limb and single joint movements, and then gradually introducing control across multiple joints. Moving on to your level 2 and 3 exercises, introducing running, but without change of direction. And eventually moving on to change of direction exercises. So these are the multi-directional change of direction exercises, zigzag, 180-degree cuts, so on and so forth. And these are some of the exercises as described. Again, there is surgery described, for injuries to the pubic aponeurosis and PA. They're mostly described from North American studies. There aren't a lot of surgeons in the UK attempting to repair these injuries. So these are mostly North American studies and repair protocols that I'm showing you. I'm only aware really of one surgical group in the UK that is attempting to repair these, namely Professor Ernest Shoulders, who's based at the Fortius Clinic in Yorkshire. So moving on, the final major diagnosis cluster that I wanted to talk about would be pubic bone stress injury, formerly known, though somewhat inaccurately, as osteitis pubis. I prefer to see this as a bone stress injury along the continuum of stress fractures. So again, diagnosis clinically is fairly easy of bony tenderness around the superior pubic ramus, just adjacent to the symphysis pubis. Bone marrow intensity in terms of uptake on stair sequences can be seen quite easily there in terms of its grading. And there is certainly some evidence that bone marrow edema intensity seen on an MRI correlates with return to play times. Although I have to throw in the caveat here that bone marrow edema can be seen in asymptomatic players as well. It's not always very well seen on MRI. I have occasionally had to use other imaging modalities such as CT and fusion images with CT SPECT, where you can see increased osteoclast and osteoblast activity across the joint. So this is another way to make the diagnosis. And we can see very intense uptake of radioactive isotope into the bone here in a patient who had symptomatic instability around the symphysis pubis and in the adjacent bone. Pubic bone stress injury, like other stress fractures, usually responds quite well to conservative measures such as reduction in training intensity. Sometimes a complete period of rest is required over 6 to 8 weeks with gradual reintroduction of activity. Obviously, rehabilitation needs to be occurring throughout this period, and if the same errors are returned to, the pain often recurs. These are the diagnostic criteria that they used in that particular study. And this is the rehabilitation guidelines that they used in that particular study as well. In terms of are there medical treatments available for this? Well, people have tried using bisphosphonates, in particular pamidronate, to treat the pain of this. Bisphosphonates have previously been used for bony pain when treating metastatic cancer, and they are well described in terms of improving bony pain. This was quite a small case study on a small number of athletes with osteitis pubis. Most did show a response to pamidronate in terms of pain. Moving on to the hip. This isn't really a cause of true groin pain, as hip pain is usually experienced somewhat more laterally, and clinically most of the time you can differentiate sporting groin pain from hip pain, but hip pain can be felt in the groin, it can be felt in the lateral hip area or radiating into the buttock, so it is an important differential diagnosis. You should do all your normal hip tests. And if you're unclear in terms of whether it's a spinal pain or a hip pain, response to intra-articular diagnostic injection can be, again, quite useful. Obviously, the hip does have some cartilage in it and an extra component of cartilage in terms of the labrum. Labral tears are very common to see even in asymptomatic individuals, so again, it can present a diagnostic dilemma in terms of is the labral tear that we see on MRI actually relevant, or is it a background finding? Again, diagnostic injection can be useful to discriminate, and sometimes exploratory arthroscopic surgery is required. This was a study done on military recruits at West Point in New York, and what they discovered was 80% or over of military recruits had asymptomatic labral tears, and even a quarter had paralabral cysts, which are again associated with labral tears. So it can be a very common asymptomatic finding, and it's important not to overdiagnose their relevance. Again, in the hip, there is this concept of femoroacetabular impingement, which is an early finding along the continuum to developing osteoarthritis in the hip. There are the two types described, the so-called CAM lesion, where there is an osseous bump on the femoral neck, and the pincer lesion, where the acetabulum has extra bone which pinches against the femoral neck. And most people seem to have a combination of the two. These are examples of x-rays from those two hip morphologies. We see a CAM lesion here, and this is a late pincer deformity and hip dysplasia, which obviously progresses quite rapidly to hip osteoarthritis even when they're quite young. This is a better example of global overcoverage and a pincer deformity, and we also see it here as well. Plenty of studies have shown now that femoroacetabular impingements can respond well to a rehabilitation protocol. In this study, 80% of people did well with a hip injection, followed by rehabilitation, and didn't need to go on to hip surgery. Again, pause the video if you want to look at these in more detail. But when surgery again is required, it does have reasonably good outcomes. This is probably the highest quality study that's been done, looking at hip arthroscopy versus conservative treatment, showing that people do tend to do quite well if they're well selected and go on to have hip arthroscopic surgery for femoroacetabular impingement. I just wanted to quickly mention a few other less common causes of hip and buttock pain. You need to recognise these when they occasionally come along. So ischiofemoral impingement is often an MRI diagnosis that prompts you to go back and look again at the patient clinically. You can bring on the pain sometimes by lying the patient prone, taking them into hip extension, adduction and external rotation of the hip, and this can cause a concordant pain. You can do an ultrasound guided injection into the area and see if the pain disappears. This is what it looks like on MRI. You often just see a little bit of muscular edema in the ischiofemoral space in the quadratus femoris muscle, and again you can see it here. People occasionally have a snapping iliopsoas tendon as it snaps over the iliopectineal eminence. This usually gives quite a deep clunking sensation and is quite easy to recognise, and again clinically isn't that often to differentiate from clicking that you occasionally get with labral tears. Iliopsoas tendon and bursa. What we've got here is some MRI sequences of edema in and around the iliopsoas muscle around the tendon. These are the axial sections. You can see it in coronal section and in front of the hip. This is the tendon, which itself looks rather normal in this MRI, but there is associated muscular edema in the muscle itself. This is a rather more severe case of a very diseased looking iliopsoas tendon. You can see it's thickened and has intratendinous signal change and a lot of edema in the muscle, and there's even an associated bursitis. This has actually got a partial tear of the iliopsoas tendon with some degree of retraction. Whereas on the adjacent side you can see an almost entirely normal tendon. You can see the difference between what's normal and pathological there. This is somebody with a very large iliopsoas bursa. This bursa was so large that you could palpate it from the skin as a large lump. It was communicating with the hip joint because of the slightly arthritic joint. This was aspirated several times, but also always refilled. So in the end, this patient required a bursectomy, and also at some point in the future, if the arthritis progresses, will need a hip replacement. And finally, never forget about the various nerve entrapments around the groin. These are the areas of sensation subtended by various groin nerves. The most well-known of these entrapment syndromes obviously is meralgia paresthetica, which usually produces anterolateral thigh pain. We also have the ilioinguinal nerve, which can be seen and needs to be protected during hernia surgery, and then other nerves such as the genitofemoral nerve. Occasionally, if these nerves are enlarged and inflamed, they can be seen on MR neurography sequences on MR, and they can also, if they're quite superficial, be seen on ultrasound and identified, and you can do diagnostic nerve blocks, but they are very difficult to prove. Often, if you've excluded all of the possible diagnoses, exploratory surgery can be performed and the nerves can be identified, released and divided. And I've had a few patients who've had peripheral nerve surgery to this effect who've had a good outcome. So in summary, groin pain is complex and requires good knowledge of the sport, examination technique, imaging techniques, and also the role of diagnostic injections. Most causes of groin pain will respond well to activity modification, good rehabilitation and injection. Surgical techniques for all of the above conditions are also described, but 80% of people with groin pain can usually be rehabilitated without requiring surgery.